Namaste, good morning to one and all present here. I am Dr. Smriti Batoye, Organizing Secretary, webinar on behalf of Department of Zoology and Environment Science, Maharaja Agrasen University, would take this opportunity to welcome you all in the international webinar on recent progress in therapeutic interventions for COVID-19. I am happy to announce that we have received overwhelming response with 1600 registrations from various researchers and academicians, not only from national but international institutes as well. Since the beginning of December 2019, numerous hospitals in Wuhan, China have reported an increasing number of patients with pneumonia due to the infection with an unknown virus. The virus, first named to 2019 novel coronavirus, was later changed to severe acute respiratory syndrome coronavirus 2, and the pneumonia was named Coronavirus Disease 2019. World Health Organization declared COVID-19 a public health emergency of international concern on January 31 and a pandemic on March 11, 2020. As of May 30, 2020, more than 15.9 million cases of COVID-19 have been reported in more than 188 countries and territories, resulting in more than 365,000 deaths. With the number of patients increasing daily, there is an urgent need for effective therapeutic interventions. In this session, our speaker will discuss several therapeutic strategies against COVID-19 infection. Now, I request our Honorable Vice Chancellor, Professor R.K. Gupta, to say a few words of motivation and encouragement. Sir, please.
Shri Suresh Gupta ji, Project Director, Dr. Sanjay Panwar, Director of School of Applied Sciences. Our today's keynote speaker, Dr. Kumardeep Chaudhary, Postdoctorate Fellow from New York, Dr. Samriddhi, Dr. Nishi Shrivastava, and other members of the faculty and dear participants. I am very happy to know that more than 1600 delegates they have registered online for this webinar. I am very happy to know that Department of Applied Sciences had launched a series of web webinars on different topics. Today, the School of Zoology is organizing an international webinar on the very important topic, recent progress in therapeutic interventions for COVID-19, which is very important in the current environment. I give my good wishes for the success of this webinar. I hope our faculty members and participants will enrich the vast experience of our expert and will gain their knowledge. Thank you very much.
Thank you so much, sir, for your words of wisdom. Now, I would like to request our project in charge, Shri Suresh Gupta ji, to say a few words of motivation.
Director of Applied and Basic पवार जी, आज के हमारे स्पीकर इनका बहुत कंट्रीब्यूशन इस मामले में माना जाएगा कि न्यूयॉर्क में इस टाइम रात के तकरीबन 1 बजने वाला होगा और वो अवेलेबल हैं और वो आज का ये सारा इसके जो टॉपिक है टॉपिक के ऊपर वो आप सभी को डिटेल में बताएंगे। उनका यूनिवर्सिटी मैनेजमेंट की ओर से बहुत आभारी हूँ कि न्यूयॉर्क जैसे शहर के अंदर जहाँ ये महामारी सबसे बुरे दौर से न्यूयॉर्क शहर गुजर रहा है, ऐसी जगह हमारे कुमारदीप चौधरी जी हमारी ऑडियंस को, हमारे जितने भी पार्टिसिपेंट्स हैं, उन सबको अभी अपना लेक्चर डिलीवर करेंगे। जो मेहनत कर रहे हैं हमारे सारे इसको कनेक्टिविटी और ये सारी वेबिनार ऑर्गेनाइज करने के लिए, ऐसी हमारी स्मृति बटोए जी, निधि श्रीवास्तव जी और अन्य हमारे सीनियर जूनियर फैकल्टी मेंबर्स जो दिन रात मेहनत कर रहे हैं बहुत दिनों से, उन सभी को मैनेजमेंट की ओर से मैं हार्दिक बधाई देता हूं। और आज के सेमिनार की सफलता की भगवान जी से प्रार्थना करता हूं। और जितने पार्टिसिपेंट्स हैं वो सब अपनी फैमिली के साथ स्वस्थ रहें। कोविड-19 से डरने की जरूरत नहीं है और भगवान आप सभी के, हम सभी के साथ है और किसी को घबराने की जरूरत नहीं है। घबराने से कोई काम नहीं बनेगा। सब समझदारी से और अलर्ट रहते हुए अपने इस कोविड-19 के इस जो है पेंडेमिक है, इससे पार पाएंगे। मेरी सभी आज के जो वेबिनार की हमारी ऑर्गेनाइजिंग टीम है, इसको पुनः हार्दिक बधाई। हमारे कुमारदीप चौधरी जी को हार्दिक बधाई और उनका धन्यवाद कि रात के 1 बजे वो हमारे लिए बैठे हुए हैं। हमारे जो वाइस चांसलर हैं गुप्ता जी, वो रात को सपने में सारी रात उनको भी वेबिनार ही दिखते रहते हैं। वो बेचारे रात दिन लगे रहते हैं कि कल कौन सा वेबिनार है, परसों कौन सा है। इतनी मेहनत कर रहे हैं, जब देखो जब फोन करेंगे तो वो यही करेंगे कि गुप्ता जी वेबिनार कौन सा है, कल अभी कौन सा है। तो मैं सभी को हार्दिक बधाई देते हुए थैंक यू, जय हिंद, जय भारत।
Now there is an announcement for the participants. Kindly mark your attendance for your e-certificate. The attendance link is visible in the chat box. Also, we would like to hear from our audience, so kindly drop your questions and queries in the chat box. Today among us is very worthy and distinguished speaker Dr. KumardeepChaudhary, postdoctorate fellow in the field of biomedical big data analyst at Mount Sinai Health System, New York, USA. Dr. Chaudhary earned his PhD in bioinformatics from CSR MTech Chandigarh in 2016. During his doctoral study, he was involved in the development of more than 20 public domain resources and prediction servers addressing the important questions from life sciences domain. He did his master's from Center for Systems Biology and Bioinformatics, Punjab University, Chandigarh, India in 2009. He has acquired over 2,100 citations from his research work so far from more than 40 high-impact international publications, including many book chapters and reviews. He was the recipient of University Gold Medal in BSc Honours Zoology in 2007 and Bird Award in 2018 for his outstanding contribution in the area of bioinformatics and functional genomics, which was conferred by BioClues organization. He is also serving as an associate editor and reviewer of many peer-reviewed journals. Dr. Chaudhary is skilled in database management system, machine learning, deep learning, data analyst, medical informatics, and genetics, and many more. With this brief introduction, I would like to invite and request Dr. KumardeepChaudhary to take over the session and share his valuable expert opinion with all of us. Sir, please.
Sure. Thank you, Dr. Batoye, for the kind introduction. Good morning, everyone. Before I start, I would like to extend my thanks to Vice Chancellor, Sir, Professor R.K. Gupta, Project Director, Sir, Shri Suresh Gupta ji, Dr. Sanjay Pawar, Dr. Smriti Batoye, Dr. Nidhi Srivastava, Dr. Sushma Negi, Dr. Mamta Bansal, Dr. Sunil Datwalia, and the members of the organizing committee and the wonderful audience for taking their time. So I'll just start sharing my screen. As we all know that we all have been going through these trying times where the COVID-19 has disturbed us all across the globe. So I'll be talking about what kind of therapeutic interventions they are being practiced across the world, and especially in the clinical trials. So I have structured my talk by introducing COVID-19 epidemiology, what are the stats across the globe in US as well as in India, then followed by the four verticals which the people have embraced to combat the COVID-19, where I'll be focusing on the global efforts and the efforts in India. And then I'll be summarizing my talk, followed by the question and answers. So first, starting with the epidemiology of the COVID-19. So this is a very good real-time dashboard provided by the Johns Hopkins University, United States of America. Here, users can come and visit the website and look at the different countries as per the burden of the COVID-19. Here we can see as of today, which is the June 5th. Here we have 6 million total confirmed cases. These numbers keep on updating. There might be some lag, but these are consistent with that of the WHO and other official global websites. And if we talk about the global deaths, we see the 393,000 deaths. And if we talk about India, India is among the top 6 countries if we talk about the confirmed cases. And needless to say, the number of cases increases as we increase the testing capabilities. Now, if we look at the world map, which is pretty concise in here, the disease or the outbreak started in the Wuhan province. And it is believed that from China, it went to the Iran. From here, it went to the Europe or UK. And from there, it spread to the east coast of the USA. Now, another route is from China directly to the west coast of the USA, which is the California side. So we can see different facilities are being provided here. We can see the world map or the country-wise map, and we can see the clinical trends, confirmed cases by different projections. Now, if we look at the temporal aspect of this pandemic across the different countries, here I'm taking 4 main countries with the context of the audience. We see in around February 16, we see the peak in the new cases in the mainland China. And if we move further with time, and we see the peak in the Italy, which is around March 21st. And if we see the difference between these 2 points, it is more or less 1 month, right? And if we further go in the United States and we see the peak of the cases, which is around April 21st. And further, we have a time lag of 1 month. And in India, we are still expecting more cases as we are experiencing, practicing more testing. And here we have ballpark number of around 30 days of the lag time. So the basic idea of this slide is that whatever mistakes or management loopholes were observed in the countries which already had observed the peaks should not be repeated in the countries which are supposed to observe the peak in the future. So how it can be achieved? It can be achieved by the close collaboration, by updating ourselves or the reading the research articles on the regular basis. Now, if we talk about the SARS-CoV-2 timeline, which Dr. Batoye has mainly described earlier in the introduction, but I'll just reiterate that on the 31st of December, when most of the world was celebrating the New Year, the first report of the new coronavirus was reported in the Wuhan, Hubei province, which was followed by on 12th of January, the first genetic sequence of the COVID-19 was released in the public domain by China. Now, this is a very important thing because all the vaccine development in case of the COVID-19 had started after the genetic sequence was available in the public domain. Because for vaccine development, we do need the sequence of the pathogen. And on the 11th of February, the previous name of the coronavirus, was designated to be SARS-CoV-2, which is the severe acute respiratory syndrome coronavirus 2. This is also important because if you see the literature from the research point of view, before 11th of February, you will find the literature maybe after December 2019 with the 2019 nCoV. So it's very important to know that two kind of nomenclature exist in the literature with this time point. And on the 11th March, it was declared as pandemic, which means it has, wreaked the havoc in most of the countries across the globe. And on the 18th March, WHO undertook the, started the solidarity trial. Now, what was that? It was a global initiative where they have decided to recruit more than 3,500 patients across 35 countries, though 100 countries showed their expression of interest. But as of now, the 35 countries are actively involved in that, where 400 hospitals are, providing the statistics for this trial. Now, if we talk about what kind of interventions are being tested in there, they are the remdesivir, which is very famous, antiviral drug, lopinavir, which is the second line HIV drug, interferon beta 1 against the multiple sclerosis, and the hydroxychloroquine, HCQ, famously known as, which is the anti-malarial drug. So now if we focus on these four drugs, we see there is one kind of repurposing of pre-existing drugs, because we don't have time to test the new drugs to get them passed through the clinical trial. As we know, the clinical trials take a lot of time. In many of the cases, they take years and years. So which I'll discuss in the subsequent slides. So if we talk about the nomenclature, the COVID, CO depicts the corona, VI for virus, D for disease, and 19 for 2019. Now, if we talk about the origin, so here is a brief, I'll go briefly. We all know they are supposed to be originated from the bats. Now which are the natural hosts. Now there are three outbreaks related to the coronavirus family members. In 2002 and 3, we noticed the SARS-CoV-1, which was originated in Guangdong province in China, spread over 30 countries with 8,000 cases and around over 700 deaths. So if we see the fatality rate it's around 10%, little less than the 10%. And the intermediate host was considered to be the civet cats. Now in 2012, we observed the Middle East respiratory syndrome coronavirus, which was originated in the Saudi Arabia, affecting the people in the 27 countries. And the fatality rate, if we see, it's around 36 or 37%. Now, if we talk about the current, the bug or the pathogen, which is the SARS-CoV-2, originated in the Wuhan, and since it's pandemic and it has already spread more than 180 countries, because these stats are from this paper, so obviously the stats has been updated. Now, if we talk about the intermediate host, the area is under the active research, where the researchers are not sure about the pangolin is definitely the intermediate host, or there might be some another mammal. So if we compare the respiratory viral infections, for example, the flu with the COVID-19, the SARS and the MERS. Now we see here we see the R0, which is the reproduction number of a virus. What does it mean? It means if a person is infected with a virus, how many other person the infected person can infect as a follow-up. So if we see, we can see for flu it's 1.3, for COVID-19 it's 2 to 2.5, though in some of the countries the number is higher, but these are the median values. And for SARS it was 3, and for MERS it was less than 1. Now what we can depict from R0 value, if the R0 value is less than 1, the virus gonna get removed from the population after a certain point of time. But if it is more than 1, so it's a matter of concern. Now here we can see the SARS has R0 value greater than that of the COVID-19, and also the fatality rate, which is the second row. It's 9.6 to 11%, or we can say around 10%, where we mentioned that the MERS fatality rate was 34%, while the COVID fatality rate is around 3.4%. As the sir mentioned earlier, only 20% of the people who get infected, they show the severe symptoms. 80% of the people, they went well even after the infection. And the incubation time, we have a longer incubation time in case of the COVID. So here we can see in the hospitalization rate, it's around 19%, which is pretty high. And in SARS and the MERS, they were like around more than 90% of the cases, they were hospitalized, the patients were hospitalized. So the question comes, if the R0 value is lesser than that of the SARS, as well as the fatality rate is lesser than that of the SARS, why it is a matter of concern, the COVID-19, why it is being so highlighted in the media or around us every day, every time we wake up in the morning. So the reason, the answer to that problem is that if we talk about the MERS and the SARS, there were very little asymptomatic cases, but if we talk about the COVID-19, we have the asymptomatic cases. For example, here I have taken 3 examples. For example, the first one is the symptomatic case where the patient is COVID-19 positive and he or she is presenting with the symptoms. But there may be the cases where the person is COVID-19 positive, but the person doesn't show the symptoms. Now, this is a very concerned situation where the person can be the carrier and might be able to infect other people who might not be able to bear the burden of the virus or the bug. So there's nothing to worry about the COVID-19 negative people. Now, if the symptomatic person gets recovered, let's say after a few months or a few days, not the few days, maybe few weeks. So there might be the 2 possibility for the person. That person may come again to the hospital with the, we call in the hospitalization term the resubmission to the hospital, or the person may infect the other person, right? So the basic idea is that the asymptomatic, the people who might be COVID-19 positive, they are the real reason for spreading of this virus up to the level of to create the pandemic. So what is what's the solution for this? The only solution right now, because we don't have any approved dedicated intervention or drug or vaccine for the COVID-19. So what we can do right now, we can do the quarantine, we can do the social distancing, or we can adopt for the use the masks in our day-to-day life. So this line plot shows clearly the countries who have adopted the mask in the starting. They are showing the flattening of the curves with respect to the countries who have not adopted the mask in the starting, but now they are realizing that the mask adoption can be proved very effective. And now there are scientific studies in the top journal NEJM or the Lancet or JAMA, where they have scientifically proved that the mask definitely stops this infection rate. Now, for the broader audience who are interested in the research as well, here we can see the amount of the research articles. If we focus on that, if we focus on these keywords, where I have put the multiple keywords representing this disease or the pathogen, we see as of now within the past 1 year, primarily within the last 6 years, we have around 19,000 research articles published in the PubMed. That's a huge number, and you can see the amount of people involved in this kind of research due to the gravity of the situation. And if you talk about the preprint server, which is a bioarchive, which means you put your manuscript online on a preprint, but it is not peer reviewed. And at the same time, you can put in any of the journals of your choice. So here we can see around 4,700 articles they have been submitted, but not peer reviewed in this preprint server. This is very famous preprint server, and it has also started its own medically dedicated server, which is the Med Archive. So now coming to the four verticals to combat the COVID-19, the global and the Indian efforts. So how we can combat the COVID? We can do the surveillance, we can do the diagnosis, where we have heard recently that the diagnosis is the key. We can trace the origin of the COVID-19 or the mutants, because we know that the different strains of the COVID, the SARS-CoV-2, they are getting mutated, and definitely we can follow up the interventions where we have to go through the clinical trials for sure. So I'll be focusing one by one briefly on the first three and in detail in the last one. So when we talk about the surveillance, what does it mean? It means that how many people are getting affected or infected by this pathogen, and how we can restrain other people from getting infected. So in these times of the social media, or there is a high probability of the fake news, so it's very important to rely on the reliable sources or the official sources. So I have just mentioned here the three of many reliable sources. One is from the WHO. Here we can see the dashboard and the number of the cases in the form of the bubble plot. As of today, it also shows the similar, if not exactly the similar number what I showed you in the Johns Hopkins University, because there is some lagging time for updating the numbers. The another one is about the Reagan Foundation, which is associated with the Food and Drug Administration. We all know the FDA agency in the US, which is responsible for approving the drugs for the treatment of the diseases, and definitely for the COVID also, including the diagnostic tests. Here we can get the list of the authorized companies who are involved in developing the COVID-19 therapies. And the third website is from the ICMR from India, where they have, this is just a snapshot which mentions there are like around 4 million samples have been tested, where 143,000 have been tested in the last 24 hours. So we can see the scaling up of the testing. As we know, the testing is one of the keys to combat the COVID. Now, we all know the Arogya Setu. This is the example of the data analysis as well as the artificial intelligence, where we have the infrastructure or the software at the palm of our hand, where we can do the contact tracing. We can know whether we have been near to someone who has already been infected with the SARS-CoV-2. We can also come to know about the syndrome mapping and do the self-assessment as well. And another example of the management under the surveillance vertical is that we have seen recently the government of India has categorized the different territories or the sections or districts into the red, orange, or the green zone, depending upon the severity or the number of the cases. And we can see the administration can prioritize their management to contain the patients in the respective areas, so that they can put the proper they can implement the proper restrictions in the required areas, and not the other areas where it is not so severe. Now, the another area where the surveillance helps with the with the accumulation of the data with the time. We can develop the different simulation models which can predict how the COVID-19 curve would look like. For example, here we see the three kind of curves. One is the red one, which is the generic epidemic growth, doubling every 4 to 7 days. Now it will reach up to the peak, but definitely go down due to the different factors, which may be due to the stochasticity of the early dynamics or the spatial variation. Social distancing is shown by the green one. It definitely helps in flattening the curve, but the blue one shows if restrictions are removed, so we are more likely to see the second wave. Now, it has also been observed in the 1918 pandemic of the Spanish flu with the removal of the restrictions. So there was a second wave which we need to be take care of. Another example is now Apple and Google, two giants, have joined, they have made the partnership where they are tracing 3 billion people in the Western world especially. And the very good thing of this partnership is that the identity of the patients is not revealed at all. That's very important, because when we talk about data simulation or using the patient level data, we have to be very careful about that we don't reveal the identity of the patients, which comes under the HIPAA compliance. So I'll take the liberty to explain one of the works under this domain, which I was involved recently here in New York City. So I work in the Mount Sinai Hospital, and here we have a lot of patients admitted in the past 2 months due to the COVID, and we were focusing on the acute kidney injury. So acute kidney injury is nothing but when someone's kidney stops functioning abruptly, right? So in this plot, we can see the y-axis is the renal function, the x-axis is the time. So we see if the insult means something happens to the body or there is damage to the kidney. So if the renal function goes down but it resumes, we call it the full recovery of the kidney function. If we see the dark green line, if it doesn't resume to the normal, we call it the chronic kidney, which is the CKD. And if it goes more worse, we call it acute on chronic kidney disease. And if it doesn't recover at all, we call it end-stage renal disease. Now, what happens if it goes to the stage 4? So the dialysis is the only option. So we have observed in the hospital also, as well as this story highlighted by the New York Times, which mentions that there is a dire need of the kidney dialysis due to the COVID pandemic. And just to put the things into the perspective here, I just wanted to highlight that you can see the tents. These are the temporary hospitals where there are a number of beddings inside those. And this area is, from the Central Park, which is for jogging and running. But they have acquired this because there is a lot of strain on the hospitals. And you can see here, this is in this building. It's a part of the Mount Sinai Health System where I work regularly. So in our analysis, what we found, we divided the AKI stages, which is acute kidney injury, into the 3 stages. The stage 3 being the worst one, and the gray square or the gray color shows the dialysis requirement. So in the overall cohort, we found that the the stage 1 and the stage 3, they were the most prevalent one, with the 35 and the 45% of the samples. But if we talk about the intensive care unit cohort, which is little over than the 550, we see that the stage 3 is prevalent, which is around, let's say, 64%. So which makes sense, because stage 3 being the severe one, so the patient, they require the ICU infrastructure, or let's say ventilation, intubation, etc. While if we compare that with the non-ICU patients, so we see the stage 1 is greater than that of the stage 3, which means the less severe AKI is there, and also the requirement of the dialysis is also low in non-ICU patients. If we then we map the creatinine trajectory across all the 3 stages as well as the recovered cohort. So the lower line, pink line, is the recovered cohort, and when we go up is stage 1, 2, and 3. So we see this the very severe stage, which is the stage 3. We see the shooting of the creatinine levels, at least for the first week. So x-axis is the day and the y-axis is the level of the creatinine. So we see that for the first week, we see a very high elevation in the creatinine level in the patients, which gets flattened in the second week. But this gives the impression that once the patients with the COVID, they get admitted to the hospital, they are supposed to show the constant elevation in the creatinine, at least for the first week. So I'm not going into the detail of this work, but to conclude this part, what we found that AKI is common in the COVID-19 hospitalized patients in the New York City, and the AKI is associated with the worse survival and the severe complication, which makes sense. And around half of the patient in our cohort, they do not recover the kidney function, which is definitely a matter of concern. Now coming to the second part, which is the diagnostic. So we have two methods. One is the RT-PCR, and the second is the antibody testing. So when to use, which out of these two tests, when to use which one. So let's say if we want to know the person, or if I am sick of my sickness is due to COVID or no, so I'll directly do RT-PCR, which is a real-time polymerase chain reaction, or I'll test for the antigens. Antigens are the part of the coronavirus proteins, or the full proteins which vouch for the presence of the pathogen in our body. So, but if I want to know that I have already been, infected, let's say 1 week ago or a couple of days ago, then I'll go with the antibody-based testing. So here what happens, we look for the IgG or IgM antibodies, where IgM represents the acute response after, let's say, 7 days or a couple of days after the infection, and the IgG represents the convalescent response, which is a long-term response. So we look for these two antibodies, and we decide, yes, the given person has been infected previously with the COVID-19 or the SARS-CoV-2 virus. So this is just the representation of the antibody testing. For example, the spike protein get recognized by the antibodies. So here we see in the part B, the IgM and the IgG curves, the antibody concentration, the acute as well as the convalescent response by the body. And these are the kits available in the market. So here, where the S is written, we see the sample from the patients, or the participant is put in this space, and we see if we see the bands in the T, which means it's a positive. If we don't see the band in the at the level of the T, but on the C, which is the control, we say it's a negative one. Now, when we talk about the antibody-based testing or any kind of testing, the two primary criteria are to ask for is the sensitivity and the specificity, which shows that how many positive have been tested actually positive and how many negative have been identified actually negative by the respective test. Now in market, there are different versions of the test, and it also depends upon the mutations which are occurring with time in this pathogen or the different strains of SARS-CoV-2. So there are different versions, and they are also in the clinical trials. From India, there's a good news from the IGIB New Delhi. The scientists have developed the CRISPR-Cas based antibody, which is equivalent to the RT-PCR. They have developed that, and they are in the earlier phase of commercializing that technology. Now, the third vertical is about the origin, where we focus on how the virus or different strains are getting evolved with time. So here we are, technically we are making the phylogenetic analysis, and we are analyzing the changes in the mutations. So for the researchers or the audience who are interested in doing such kind of analysis, so this is a very good website where most of the people are submitting the RNA sequences, or we can say the genome of this virus, which is around 30,000 bases and a couple of proteins. And anybody interested can download the data and they can do respective analysis. So I'm just going to highlight the recent paper by the by a group from the IGIB, where what they have found the novel cluster, which they named I/A3I, which was not reported earlier anywhere in the world. And they have, based upon the comparative phylogenetic analysis as well as the mutation rate analysis, they have found this cluster, which was specific and novel in the Indian population. So if we see about these bubbles, the size of the bubble represents the number of genomes. There were around total 360 genome, more or less 360 genomes, out of which 145 genomes, they have the variants for this clade, right? And here we can see from the Telangana or Tamil Nadu or from the New Delhi, we see the higher proportion of this purple color, which means the proportion of this variant is high in these areas. And the established A2A clade is prevalent in the Gujarat area and the other Madhya Pradesh, as well as the other area we can see. So here this tree represents the phylogenetic tree, and here the single point represents that it has been started from a single point of time, and then it has spread to the different states across the India. So now coming to the main part, which is the intervention. Here I'll be discussing about the vaccines, drugs, Ayurveda, convalescent plasma, or the homeopathy. So for every kind of intervention, we have to pass through the clinical trial. So I'll try to explain very in a simplistic way. So when we do the basic research or the discovery research, we start with the thousands of compounds or the vaccine candidates, I would say, and then we end up with around hundreds of them. And it takes around a decade or 3 to 6 years at least in the discovery research, right? We call it the preclinical phase. Now the idea is to how we can narrow down this space in the context of the time, right? Now that is followed by the phase 1, where the primary objective is to assess the safety of the molecule. They are not concerned about the efficacy, but they are concerned about the safety of the molecule. And the number of volunteers, they may range from 20 to 100 more or less, but they are healthy individuals, because the candidate molecule or the vaccine candidate, it shouldn't be harmful to the healthy individuals. That's the first and the primary criteria to start with the phasing. Now the phase 2 focuses on the efficacy, the safety. Though safety is definitely a concern, but the more focus is on the efficacy, because the safety has already been assessed in the phase 1. So here we scale up the number of the volunteers from few hundreds to 500. And in the phase 3, we are definitely concerned with the efficacy and the safety, but the number of volunteers go like few thousands to couple of thousands, right? And the phase 4 is like the post-marketing survey and all the stuff. So here, in most of the cases, whatever I'll be talking about, our drugs or interventions are in the phase 1 or 2 combined, or phase 2 or phase 3, because if we talk about the new drugs, it's very difficult to get them passed through easily, because if you look at the bottom, we have 6 to 7 years of timeline to get a candidate molecule to pass all the first 3 phases. So this is the recent data which I have taken from the clinicaltrial.gov. If somebody is interested to know what is the recent trend of the interventions or the drugs or molecules, they can definitely visit this website, which is regularly being updated and taking the global data. Here we can see we have around 1982 trials related to the COVID, which are being pursued across the globe. And if we see in India, or we can see the India or Pakistan, we have around 27 trials, the maximum being in the Europe. In China, we have around 130, and in US, we have little over than the 400 trials being carried out. So, which shows that there is a huge effort being taken by the researchers or the clinical physicians, administration as well, to combat this disease. Now, if we talk about what kind of interventions are being taken in these intervention trials, so we see that more than 50% of the trials they are represented by the drugs, which means remdesivir or some other kind of drugs are being tested in these trials, followed by the biologicals. In biologicals, we include the clinicaltrial.gov include the vaccine candidates. We know there are around more than 100 vaccine candidates which are being supported by different groups and being tested proactively. So there are few diagnostic tests which makes around 3% of those, few devices where the machine learning or artificial intelligence or Internet of Things comes into the place. a few dietary supplements, which are not the drugs like the probiotics or something like that, which may enhance or boost the immunity of the participants. And there are miscellaneous, which may contain different kind of interventions. So from Indian perspective, if we have to get the update, what kind of clinical trials are being carried out. So this is a very authentic website, which is the Clinical Trial Registry India, ctri.nic.in. So I would say that somebody interested to know the current status, they can definitely visit this website. And we did some preliminary analysis, and what we found the trend different from that of the world. So here you can see the Ayurvedic components like ashwagandha, guduchi, or let's say Ayush 64, including some others, because these three are mainly used in these Ayurveda based trials. So they constitute around 36% of the interventional trials, followed by the regular drug. By regular drug, I mean the drug which are being used in the allopathy, for example, remdesivir, hydroxychloroquine, etc., which is followed by the biologicals. In biologicals, we have put the convalescent plasma related trials, which I'll discuss in the subsequent slides. And we have 10% of the trials dedicated to the homeopathic interventions. So the vaccine, which are focused on the mycobacterium, heat kill mycobacterium based, as well as the BCG vaccines. They constitute 8% of the trials in India. And the miscellaneous ones are 13%. They include the Siddha, they include the yoga, they also include some other interventions. Now, if we see the corresponding the phases in which these trials are running right now. So I have highlighted here 4. For example, for Ayurveda, we have trials running in the phase 2 to 4. For some of them, we don't have trial information. For drug trial, we have phase 2 and 3. For the biological trials, which is primarily the convalescent plasma, we have trial from the phase 1 to till phase 3. And for the vaccine, we have from phase 2 to phase 3. But here we can see in Ayurveda, which is a little bit advanced, because Ayurveda, we don't have to go to the phase 1, because primarily they are well known to be the safe, as they have been practiced into the community for a very long, very long time. So this is a summarized view of the trials in the context of the phase in the overall trials. So here we see most of the trials belong to second or the third phase. We still have to cross these bars to reach to the interventions to the market. And if we talk about the funding, the government is supporting heavily, which means 50% of the trials are being supported by the agencies, which are government agencies. And we see 20% of trials, and they are in partnership with the industry, or in collaboration of government or with that of the industry. And in the miscellaneous, we have either the private hospitals or the individual or the NGOs which are running the trials, of course with the permission from the DCGI, which is the Drug Controller General of India. Now, if we look at the randomization of the trials, and that's a very important point, because generally when we do the trial, we make the 2 groups. The one group which is given a dummy solution, which we call the saline solution, or maybe the placebo. The another group which to whom we give the actual intervention, or the drug, or the Ayurvedic medicine, or you can say the vaccine. Now, the randomization is a way to remove the biasness, which means when we assign the individuals or the participants or the volunteers to the 2 groups, we don't want to bias or ascertain ourselves regarding the distribution of the individual in the 2 groups. So the randomization is very important. Whenever you look for a trial, you have to look whether that trial has been done, the randomized controlled trial or not. So here we can see most of the trial. There are different categories of the trials in the context of the randomization. But if we look across the y-axis or the labels, we see mostly we find the word randomized, though the design may be different, but definitely randomization has been practiced. So which is very good thing because we get the unbiased results at the end of the trial. So this is the timeline which I have made. Here we see across the x-axis, we have the estimated duration of the trial. And here in the middle, I have plotted the dotted line. The right side of this dotted line represents if the trial has been tested on the actual COVID patients, and on the left side, if the trial has been tested on the healthy volunteers, right? And if you look at the y-axis, you go from bottom to up, you see the actual date of first enrollment from April 8 to the June 15th, right? So this data has been taken from the CTRI, and I have tried to compile it to make it a comprehensive visualization. Though it might not be the best, but it is still which we can carry some message away with. So here we can see there are most of the trials, they are testing on the actual COVID-19 patients, and very few trials they are focusing on the prophylaxis, which means they are healthy volunteers. Now why they are doing so? Because we know the healthcare workers, they might be in the vicinity of the actual COVID patients. So they need to take something to prevent COVID, to prevent themselves being the victim of the COVID-19. So there are the few concepts of the prophylaxis. We call that pre-exposure prophylaxis, which means when the person has not been exposed to the COVID person or the COVID atmosphere. The another strategy is the post-exposure prophylaxis, where if let's say the health worker has been exposed to the COVID ambience, so what kind of medicine he or she can take. So, and another concept is that if we recall the slide mentioning the COVID-19 subtypes, we recall there were healthy individuals, there were asymptomatic, there were severe patients of the COVID. Now there might be another class which is like the mild or moderate symptoms. So we see that for different kind of patients or the volunteers, there are different kind of drugs, right? So I'll first focus on the vaccines. So here we see the overall timeline of the approval of the vaccines in case of the antivirals treatment. Here we can see till now for the given names on the vertical, we see that for Ebola and the dengue, only two vaccines have been approved in 2019, and for rest of the manifestations, there is no vaccine approved as of now. So vaccine attempt is a 50-50 risk, where we see some of the successes in the chickenpox, smallpox, but we don't have vaccine for HIV as of now because of the high rate of mutation. And for COVID also, we are very optimistic, but we have to wait to get the positive results. So what are the top contenders right now in the clinical trials? So here I have listed from this paper the top 5 contenders, where I like to highlight this messenger RNA-based vaccine from the Moderna, which is in the limelight nowadays. Why is it so? When we talk about the vaccine, it may be the attenuated viral particle, it may be the killed viral particle, it may be some segment of the virus which may elicit some immune response, right? So now, if we talk about the other viruses or the second other vaccines, the second one or the third one, which are against the S protein, which is the spike protein on the surface of the virus. The first one is very novel approach, where they are not making the vaccine for the protein, but rather the messenger RNA, which makes the spike protein. Now, the benefit of this is that now, since you are not inoculating the virus itself, but the messenger RNA only, so there is a very low risk of cross-reactivity or and the harmful effect or the side effects. Further, the second advantage is that when we generate or develop the vaccines, even let's say the vaccine get approved in the phase 3, now you have to develop at scale. So now we use the the traditional methods of using the eggs to develop the vaccines and all that, which is very time consuming. So now, since it is an mRNA based vaccine, it can be developed synthetically in the lab at a high scale. That's another benefit of that. Now, recently we have observed the results of the phase 1 trial of the messenger RNA 1273 vaccine, and that has been shown the positive results. Now, currently, this vaccine is under the phase 2 trial, and I have recently heard a day or two back that in July they will start the phase 3 trial. Now, you can see how expedited they have done the trial for this candidate as compared to the other ones. Now, the second candidate is from the China. Now, they are also showing the positive results. They if I'm not wrong, they are submitting the results in the high-profile journals so that they can be shared by the scientific community across the globe. But right now, the Moderna's mRNA vaccine is the top contender if we talk about how successfully it's been switching from phase 1 to 2, and maybe probably, if everything goes well, from phase 2 to 3 in the July. So in India, what's happening? So I have broken down this the previous timeline into in the context of the vaccines. So in India, there are only 2 vaccines which are underway right now, which is the heat kill Mycobacterium W and the recombinant BCG. Now, we all know the BCG is given for the tuberculosis, almost everyone in India in their childhood. But the new contender is the Mycobacterium W. What it does, it was discovered to be beneficial in case of the leprosy. Now, we all know that the tuberculosis also affects the lungs. Now, the site of infection is the lower respiratory tract in case of COVID, as well as the Mycobacterium tuberculosis. So here they are trying the candidate from the leprosy to treat the COVID. Now, even if I'm not wrong, the PGI has started the trials with this vaccine candidate, which is the MTBW, along with the AIMS Delhi or AIMS Bhopal. So we have to wait for, let's say, a couple of weeks or say a couple of months to see how the results look like in Indian subcontinent. Now, the another aspect is the drug. Now, when we talk about the drug, we know there are many or thousands of drugs which have already been approved by the FDA. So the traditional approach is to look for the drug, the new drug, and then to get it passed through different phases. Now, if we are looking which are already approved drugs by the FDA, and if we could find if they work for the COVID, I mean, we don't care if they were approved for the cancer or some other antiviral or anti-malarial disease, but even if they are working well for the COVID-19, then it will be a very safe bet and it will be very quick. So from this plot, we can see if we compare the return with that of the risk, the novel drug have high risk as well as the high return as compared to the repurposed drugs, right? So that's why it takes the lesser time in the clinical trial, less than 1 to 3 years, because you don't have to go to the phase 1. You directly start with the phase 2 onwards, and then you can shorten the time frame. And the success rate, you see the success rate is 30% as compared to the 0.01% success rate if you vouch for the new drug. So that's the power of repurposing. Now here in India also, as well as in the world, the news have been with the hydroxychloroquine, remdesivir, and the new the indigenous candidate from this plant, Cocculus AQCH, which is from the plant. So I'll go one by one, and if we look at this plot, it is these drugs are primarily given to the people who are actual COVID-19 patients, and very few to those who are pre-exposed to the COVID-19 ambience or for the prophylaxis per se. So if we talk about the remdesivir, it was approved. It was tested for the Ebola. And if we see when the SARS-CoV and how it works, we see the spike protein gets interacted with the ACE2 angiotensin converting enzyme 2 receptor along with the TMPRSS protein, and it gets internalized to the cell. Now this compound, which is a prodrug, gets converted to the active compound, and it inhibits the RNA-dependent RNA polymerase. Now, if it gets halted, there is no replication of the RNA with the virus, and thus the replication of the virus is getting prohibited. So this is the primary mechanism. So there are ongoing trials in many countries along with the solidarity trial, and we are waiting for the positive results, or what kind of results are coming in the near future. That will be interesting to see. If we talk about the HCQ, so HCQ, it primarily increases the pH of the lysosomes and renders the replication or the fusion of the endosome with that of the lysosome, because it's a alkaline in nature, and thus it inhibits the replication of the virus. So now there is we have seen a lot of interesting developments in case of the HCQ. We all know that it has been requested by US from India and touted by the US president, and now there are different studies which have come up with the HCQ clinical trials where we are getting a mixed kind of response. And but we the bottom line is that we have to wait for a couple of more trials to get out with the results, so that we come to the conclusion whether HCQ is good for the SARS-CoV-2 or not. Even the ICMR has suggested HCQ only for the extreme cases and not for the regular cases. So it has to be taken with a pinch of salt. So if we talk about the Ayurveda, so 3 Ayurvedic interventions, Ashwagandha, Guduchi, and Ayush 64, which was for anti-malarial, I guess, they are in the clinical trial, and we can see there are a lot of trials which are under way right now. You can see from this plot, and equally you can see the equal distribution for the prophylaxis as well as the actual patients who are suffering from the COVID-19, maybe from the mild. They are primarily the mild to moderate symptoms, not the severe symptoms. As we know, the Ayurveda approach boosts our immunity, and it doesn't kill. It doesn't actually kill the pathogen, but it enhances the second aspect, which is enhancing the immunity of the host. So that's why the volunteers, they belong to the mild to the moderate symptoms, not the severe symptoms. Because for the severe symptoms, the only allopathic drugs, remdesivir, HCQ, they are preferred. But recently, the research from the IIT Delhi, they have published a paper, though we have to be mindful that the paper was based upon the molecular docking, where they have shown the vidanone, which is a compound from the ashwagandha, it has a better binding capacity with that of the main protease, which if it binds to that, it halts the replication of the virus in the host cell. Though it is a in silico study, but definitely it is a positive sign where the Ayurvedic medications, they have been victim of criticism because they are not being shown any progress in terms of the contemporary science when we talk about the clinical trials. But now if we see the clinical number and the effort of the clinical trials in India, it's a very positive sign, and we hope that one day they will be taken as a regular point of care medications, at least for prophylaxis for SARS-CoV-2 infections. Now, before going to the convalescent plasma, if I take the liberty to recall the slide here, mentioned previously, if we see if a person who was suffering from the COVID-19 positive gets recovered, so we can take the plasma with the assumption that that person might have developed some antibodies, right? And then we take the plasma and we can insert that plasma into the new patients who have been suffering from the COVID-19 symptoms. So if we see the trial status in the CTR from the CTRI website, these all are COVID convalescent plasma trials. We see they are primarily given to, except for the one trial given to the patients who are actually severe COVID-19 patients, right? So the brief mechanism is when the plasma is taken, we have different components in that: clotting factors, antibodies, anti-inflammatory cytokines, albumin, protein C and S, which help in the blood clotting mechanism. So this yellowish thing is taken from the person who has recovered recently from the COVID infection, and that is being inserted or inoculated into the new patient with where the plasma serves the two purposes. One, it has the antiviral effects. If you recall, we talked about the immunoglobulin G, IgG, IgM, which are the neutralizing antibodies. They act primarily on the spike protein. They identify the spike protein of the pathogen, and then they try to neutralize that. Apart from that, and the plasma also helps in the immunomodulatory effect, which means it tries to enhance the immunomodulation of the host. Here we can see, if we talk about the adaptive immunity, so it helps in neutralizing the cytokines, complement system, or the autoantibodies. We heard about the cytokine storm. It tries to pacify that storm or the inflammation or the hyperinflammation in the body. And if we talk about the innate immunity, we see the elevation in the interleukin 10, which is the anti-inflammatory cytokine, and the other contemporary cytokine with the similar properties. So with this, I'll try to conclude my talk, where in this talk, we have seen the basic epidemiology across the globe, along with the efforts here in the Western world, where I have mentioned one of my studies, which is under review. It's not published. It's in the preprint server related to the acute kidney injury. We talked about the 4 verticals, from the surveillance to the diagnostic kits, to the origin or the evolution mapping of the pathogen, to the interventions, which included the drugs, the vaccines, the convalescent plasma, and the other kind of interventions. And we have specifically focused on what kind of candidates are running at the front end in the clinical trials. If we talk about the vaccines, so there is a Moderna's mRNA vaccine is the front runner. If we talk about the drugs, the remdesivir is the front runner, where the hydroxychloroquine still needs to prove its feat in this area, because there are mixed kind of studies coming in the literature. If we talk about the Ayurveda, we see the 3 main candidates which have been adopted by the community for many long years. They are being tested now scientifically. That's very important, because that's for our own confidence that the Ayurvedic interventions, they can, if they are proven to be beneficial, that will be the first time. I would say it's a blessing in disguise that will be the first time they are, evidence-based. They are making the evidence-based medicine. So with that, I would like to acknowledge Dr. Girish Nadkarni, Dr. Koka, Dr. Chan, and the Mount Sinai Health System for the AKI-related study, and Dr. Shari Bhalla for helping me in generating all the clinical trial-related figures and analyzing the data. And now with that, I thank you everyone for your patience, and I'm open for questions. Thank you.
Thank you so much, sir, for sharing your knowledge with us.
Sure.
Now the session is open for questions, queries, and discussion. I would like to hand over the screen to Dr. Mamta ma'am. Ma'am, please.
Right. So the first question is from Dr. Avneet Kaur. Ma'am is asking, Is plasma therapy is effective and to what extent? Ma'am is asking this, please, sir.
Yeah, so the plasma therapy is effective. It's not the first time they are using the convalescent plasma therapy. It has been used earlier in 1918 as well, with the viral infections at that point of time. The only thing is, since when we talk about the definitive effectiveness, we have to wait for the results of the clinical trials. And right now, the results of the clinical trials are not out yet, because even the trial, the recruitment is over. There are a number of steps the administration has to go through. So we are hoping that we, after, let's say, within 1 month or within a couple of months, we will be having the results for that across the globe. Yeah.
Yeah, thank you, sir. And there is one query from Saurabh Taneja. He's asking, during raining season, will this virus is more dangerous and increase in number?
So as per the experience from the other members of the coronavirus family, it is expected that in the fall season or in the season when there is moisture, there is a high susceptibility of the infection being spread in the community. But since there is no scientific evidence as of now, because this thing has appeared for the very first time, and we're gonna experience this, the moist season or the rainy season for the first time. So scientifically, I would say we don't have any data to support this, but you can definitely speculate, keeping in mind the experience from the other members of the COVID family, coronavirus family.
So this one question is very important and asked by participants like Vinod Kumar, Mrityunjay, and one person from Indonesia. They are asking, these questions are very relevant and you have covered your talk also. They are saying there are some herbal like jamu to prevent COVID-19. This concoction contains ginger, turmeric, lemongrass, lime, honey, cinnamon, etc. And effective, and people are using it maybe in India, or traditional people are using this concoction. And some light on this, sir, please.
Yeah, so that's a very good point, but I'd like to answer this point scientifically. Like I mentioned, the Ayurvedic or the home remedies, they have been criticized in the scientific community because we don't have any scientific evidence. What do I mean by that? Nobody has done any scientific experiment which is statistically rigor to show the point that yes, the people or the individuals or the volunteers who have used these kind of interventions, they show better immunity with respect to the ones who don't use those, right? So that's why I said, if you go to the CTRI, you will definitely find turmeric or maybe lemongrass. I don't recall, but you definitely find the turmeric. You can put the keywords and you can do the search in the CTRI website. There are a number of trials which use the turmeric right now, but we have to wait for the results in the context of the COVID, right? But definitely people might have used the turmeric in other trials which might be used for other diseases, and you may find those in the CTR. One point I want to highlight that if you go to the clinicaltrial.gov, you might not find all the Indian trials there, but in CTRI, every trial which is happening in India is mandatory to get registered with the CTRI. So you will find all the Indian trials in the CTRI. Yes, definitely. We need to perform the evidence-based medicine when we talk about the Ayurveda, and this is a very good opportunity for all of us. If anybody is interested, they can collaborate with the people they know around them, and they can contribute in this field.
Right, sir. Right. And this is the last question for the session, which is asked by Chanchal. She is asking practice and not good for health. Can you please have some points regarding use of mask and use, sir, please? She is asking about mask, uses of mask.
Okay, yeah, I got the question. So there are a couple of points. The very first point is having any kind of mask with respect to not having a mask is definitely a better thing, right? If you have any kind of mask with respect to the condition, you don't wear the mask at all, is definitely a plus thing to prevent the infection. Now, there are different categories of masks. Now, there is a scientific study, I don't recall the name of the authors, but they have shown, or I may send later on through the email or somewhere else, that they have shown that different kinds of masks have different preventive capabilities in terms of the distance, in terms of the aerosols, in terms of the particle size, right? So if you might be aware of the media, the people or the doctors who work in the close vicinity of the COVID-19 patients, they are given the N95 mask. But the people who are, who are like who don't go in that proximity to the COVID-19 patients or in the hospital system, they are I would say okay with that of the surgical masks or the other kind of mask. But definitely wearing a mask will save somebody who is not using the mask at all.
Right, sir. There are many other related questions which you have. They must be clear with queries. And thank you very much, sir, from my side. It was a wonderful talk and we have learned a lot from you. Thank you very much, sir. Over to Dr. Smriti, please, ma'am. Thank you, sir.
Thank you. Thank you, Dr. Mamta.
Thank you, ma'am.
Thank you, Dr. Chaudhary, for enlightening us and resolving the queries in simplistic way and providing answers to many issues. Thank you so much, sir. We
Thank
feel
you.
fortunate having you here. It was a great to be a part of this knowledgeable and worthy session. Thank you, sir.
Thanks. Thank you.
In the end, I also would like to thank our Honorable Vice Chancellor, Professor R.K. Gupta, Project in charge Shri Suresh Gupta ji for continuous support and guidance. I would like to thank our Director, Dr. Sanjay Pawar, School of Basic and Applied Science. Thank you, Dr. Mamta Bansal. Also, I would like to thank Mr. Ajay Raheja, Network Administrator. Thank you, sir. Thank you, Ranjit sir, Kunal sir, Savita ma'am. Thank you, everyone. Have a good day.
Thank you.
Thank you, sir.